We'll be starting in just a minute. We're waiting for Dr. Irvine, who unfortunately was dropped off at the wrong building. But he'll be here any minute now, and as soon as he comes, we'll get started. Okay, we can now get started. All right, hi, I'm Amy Paller. It's my pleasure to welcome you to this meeting of the International Eczema Council. And I am going to now introduce our president, Professor Alan Irvine, who was a founding member of the International Eczema Council. Professor Irvine trained in dermatology and genetics in Belfast, Northern Ireland, in Great Ormond Street in London, and to our great pleasure with us in Chicago as well at the Children's Hospital. Since 2007, he has been a professor of dermatology at Trinity College in Dublin, and since 2002, consultant dermatologist at Children's Health Ireland and St. James Hospital. As you all know, he has published extensively in high-impact journals and has really led our field in epithelial genetics, characterization of the skin barrier, disease mechanisms, and therapy of atopic dermatitis. I could go on and on about the many honors that he's gotten, but without further ado, let me just call up Professor Irvine to the stage to tell us about today's program.
Thank you, Amy. Appreciate the introduction. I thought I'd test. There's a reputation that in South America things don't exactly start on time, so I thought I just wanted to kind of individually do a little verification to see, and it seems to be stacking out and experimentally. There's a saying in Ireland: the person who lives closest to the church is last at Mass, and I've been here for a week, so there's really no excuse for being late, but I got dropped on the wrong side of that beautiful neoclassical building, fought with somebody from L'Oreal who correctly didn't allow me into their secret thing, so here we are. Listen, it's a real pleasure to see such a full room and to be at the WCPD in South America for the first time. It's just an incredible city and an incredible country, and it's great to be able to share the IEC with so many of our South American councillors and friends, and Paula here, real leading lights in what we're doing, Paula and Valeria as well. So it's fantastic to have everybody here. Just a few housekeeping things. The session's been recorded. It'll be posted on the website and on our YouTube channel. If you have any comments about today's session, please email Alan Stiles. If you want to join, Alan's here as well. Come and shake his hand, meet us afterwards. The IEC is growing globally. It's now in 33 countries. I'd love to see this part of the world filled in a little bit more, the South American map, with people who are interested and passionate about improving care for patients living with atopic dermatitis. We have 151 counsellors and associates from 33 countries in 6 regions. And this is how we're trying to grow our global representation. You can see how it breaks down. South America is too small, 4 counsellors, 6 associates. That's not enough. We want to see more. And if you think you'd be, or one of your colleagues would be eligible for associateship or counselorship, please do contact us, contact me or any of the staff who are here, and we'll help you on your pathway to that. We want you to amplify your impact. We want to network globally so we get the best learnings and the best treatments for patients with atopic dermatitis in a regionally sensible way, and really to drive change that improves things. And this is just to reinforce the message that we have about reaching out to you and you joining the organization on the journey. We're welcoming PhDs. If you have PhDs who you work with anywhere in the world, we really want you to join. Sorry? Okay. Oh no. Okay. I was getting heckled. That was great. I really arrived. I've got a heckler. It's great. So So, assuming people aren't against PhDs, that's the anti-PhD lobby, has been expelled at the back. Please, if there's anyone who is, who's passionate about this, we've our first couple of PhD members will be admitted this year, and several more will follow at the membership committees. Just to briefly go over what our IEC mission is, and that's to improve patient care by research and education and best practices, and it's a global one. Our vision is to transform the lives of people with atopic derm. This is our 10th anniversary, by the way. Amy was too modest to say she established the IEC 10 years ago, and we're celebrating this decade this year. The anthem, we're a global community, and it's important when we're sharing time with you in South America, that it's, to advance research, treatment, and prevention. We're going to talk a bit about all of these today. And the values are patient-centered, innovative, evidence-based, globally inclusive, collaborative, and forward-looking. And we get a lot of generous sponsorship, some of whom are here today. We use that to drive a lot of educational global impact, and I'm grateful for Jennifer for collating all of this. This will be our 40th symposium. We've had 150 individual expert speakers. We try and get new voices, so if there's voices from South America who've not spoken, please do make yourself known, and we will make sure to include you and say what you'd like to speak on and where and when that suits you. We've had 26 countries represented. There's over 80 hours of free content on YouTube, and I encourage you to look at that. We've about 11 or 12,000 views on that of the 136 videos. And this is what we're doing so far. This is our third symposium. We've had the Quad AI, we've had the AAD, and this is the World Congress of Pediatric Dermatology, which we're really thrilled about. We'll also do a symposium in the SID at the EADV. We became a lot more active in social media in the last year. Whichever one of these is yours, please do join us, find us, amplify the message, and download learning materials and share them in the communities as appropriate. And particularly our YouTube Learning Center is getting reformatted to make it a bit easier to find keywords, and there'll be some AI interpretation on that as well. Any general questions, Alan? And your QR code for our program guide. Now I'm just going to stay on. I'll just roll on and do the next talk, if that's okay with the chairs. Yeah. Now you got me here. Please carry on. Please carry on. So thank you. That's a little bit about the IEC. So I'm going to, yeah. Okay. So it seems to make sense to start with prevention. Of course, we prevented and not us to be in the room. There can be no eczema, but let's see if we can try and reduce the incidence a little bit. I'm just going to talk a little bit about this, and then I'm going to be followed by Carsten, and the chairs will introduce the speakers as they come up. So I'm just going to go straight into my slides, which now do I need to click on something to bring up the next presentation? Oh, somebody else. We're kind of jointly driving the mouse. Okay, we're good. We're good. We're good. Thank you very much. So this is how we might prevent childhood atopic dermatitis, really specifically through moisturizers. And what I want to do today is just talk very briefly about the pathogenesis and what we might be trying to prevent. And remembering that atopic derm is a very heterogeneous pathogenesis. Many roads lead to atopic dermatitis, and not one intervention is going to fix all of those roads, clearly. I'm going to talk a little bit about early life events at the skin barrier, introduce preclinical atopic dermatitis, something Amy and I published on last year we think might be useful to identify people, and then maybe how can we prevent childhood AD. So just to remember, atopic derm is a complex and interacting pathogenesis. We're very focused on the immunology of it because the immunology is by far the best target to drug. It's the most tractable for small molecules and biologics. But we do have significant skin barrier abnormalities as type 2 immunity, type 22, 17 sometimes, Staph aureus and other microbiome abnormalities, all driving itch. But just to get back to the first barrier, which is really driven by corneocytes, these little organelles that that are the difference between us living a terrestrial life and living in an aqueous life. If we just desiccate and dehydrate immediately on birth, if we didn't have a really perfectly, really functional skin barrier. And of course it has immunological preloads with cytokines as well. So when we come to atopy and disrupted skin barrier, which comes first? Which is the chicken? Which is the egg? And of course there's many roads that lead to this, and not everyone who gets AD has a pre-existing barrier abnormality. But there's certainly evidence that if you have a profound enough insult on your barrier from the genetic skin diseases, that you can indeed have significant atopic morbidities purely from a really disrupted barrier. So this is just one example, ectodermal dysplasia. It's a structural defect with significant atopy, allergies, including respiratory allergies as well. Similarly, in Netherton's, atopic derm-like condition in some with significant allergies and atopy, and corneal desmosine mutations which lead to peeling skin. So there's lots of evidence in genetic skin disease that a really profound barrier defect can drive this, and at least in a proportion of people this is relevant. The big green molecule here, the green staining is filaggrin in stratum corneum. It's more than 30% of the dry weight of the stratum corneum. Really significant molecule. To protect the skin barrier and to relate to changes in the environment. Carrying a loss of function mutation in filaggrin has a lot of significant consequences. You have much higher risk of atopic dermatitis, much higher risk of food allergies like peanut allergy, and about a 50% chance of getting asthma as well, but only if you get eczema first. So there's a characteristics of eczema plus asthma that are barrier related. A bit like what we talked about with the ectodermal dysplasias and others. There's also a second hit. So once the barrier is disrupted, alarms go off here. They drive type 2 signaling, the canonical signals 13 and 13 gets amplified in 4 through these alarmins, TSLP, IL-33, and IL-25. And that just further in a vicious cycle drives things. So these things are happening early on in AD. Now I just wanted to focus a bit on the really early parts of life. So we move from being in an aqueous, completely xenobiotic experience where there's no microbiome in the uterus. That's been debated to and fro, but it's pretty settled now that they're in a healthy pregnancy. There's no microbiome in there. And we immediately pass through, by whatever route, into a xerotic environment. And that's the biggest change in your environment that you'll ever experience, your skin will ever experience, from 100% aqueous to a dry environment, and then the microbiome piles in around the hair follicles and seeds out. And there's been evidence right from the 80s, this is in rats who had pups delivered by cesarean section and then immediately moisturized, and what we see there is that there's no filaggrin breakdown in those mice, but the mice that have a normal delivery immediately start breaking down within minutes of that massive environmental change. And this comes down to filaggrin post-translational processing. So filaggrin's in utero it's held in the granular layer as profilaggrin. It's not functionally active as far as we understand. But then there's a very sophisticated post-translational modification of filaggrin from the keratohyaline granules. It's dephosphorylated, chopped up by saspase into monomers. They bind the keratin filaments. They get broken down by bleomycin hydrolase, and eventually they form this substance called natural moisturizing factor, which makes the skin supple and flexible. It's a humectant, draws water into the skin. It's also antibacterial. It's also acidifying in the skin. And you can detect this by Raman spectroscopy. We published extensively on this. And this just shows you by Raman spectroscopy. These are kids who we looked at immediately after birth on the palm of their hand, looking and repeatedly sampling them with this non-invasive, painless Raman technique, looking at minutes after birth. And you can see really by day 4, filaggrin has just all been chopped up and NMF is there in the outer layer of the skin. So it's reacting to that environment. The same way as people react in the shoulder seasons. If you live in a country where there are 4 seasons and we have spring and fall or spring and autumn, people often flare with atopic derm. People who have low amounts of filaggrin struggle to compensate for these changes in humidity, and it drives a pro-inflammatory response. And with Raman, you can identify wild-type filaggrin carriers from loss-of-function carriers. And you can do lots of extensive stuff, looking at pre-AD skin, and looking at the cheek especially. There's low NMF, ceramide abnormalities, type 2 immune skewing, and microbiome alterations are all there in kids who are at high risk of subsequently developing AD. And this comes down to the concept of preclinical AD, where all these changes exist, which I won't go into detail for time reasons, but which are almost identical to the changes that we see in clinical AD, but there's no itch, there's no erythema, there's no clinical perception of AD being there. And this is what Amy and I have determined preclinical AD, and that might be somewhere where we can treat people to prevent them progressing. So can barrier prevention do this? Well, there's been a lot of interest ever since the filaggrin discovery in 2006, 10 big trials, 2 big trials and 8 smaller ones. And this is a meta-analysis showing not much shifts the curve. But then when we go back and look and say, well, what about the biology of this? Should we try things extremely early on, remembering this curve where we're immediately adapting to the external environment, really within minutes and hours? And this is where we designed the Stop AD study conducted in Cork. We have some people from Cork here who contributed to this. So this was a single center, people randomized 1-to-1 to standard care or a proprietary product. And what we did was only treat for 8 weeks from as soon as possible, and at the very latest 4 days, but generally kids were initiated within the first 2 days. And what we saw was a substantial decrease in the prevalence of atopic derm at 6 and 12 months, just after those 8 weeks of intervention. So perhaps very early intervention is critical into making these work. Eric Simpson has recently reported another positive intervention study. So why did the big studies work and the smaller studies show some signs? Is it randomness? We don't think so, but it's probably quite complicated. What we did see in this, which gives some biological plausibility, is that the kids who carried filaggrin mutations did much better, got much more benefit than those who did not. And that makes sense. If we say there's many different ways to developing AD, people who have an inherited barrier defect do better with barrier supplementation than those who do not. And there's a lot of complicated science around this, which I have a short time slot, so we won't go into it. But essentially, the number needed to prevent in filaggrin carriers is much less than the number needed to prevent in people who are filaggrin wild type. And we had good adherence to the study. So just some conclusions. Intervention trials have shown really very different results, from being quite promising in the early studies that Eric did to disappointing in the larger studies to now smaller studies showing hope again. So we need to understand that. The timing of the intervention, the emollient characteristics may make a difference. Stratified interventions based on phenotype or genotype, phenotype being a Raman phenotype, which is a proxy really for genotype, they may be important, and further replication, of course, is needed. So these are the many people who've been involved in the study, funding it or conducting it, and these guys, just want to say thank you for looking for them. Yeah, it's a Peds Derm audience, everyone loves these. So thank you, apologies for running on Irish time.
No, afterwards, no? Questions at the end?
Questions at the end.
Yeah. So it's, my turn to present Dr. Castor Four. He has a particular interest in novel methods of AD prevention and how AD links with food allergies and therapeutics, especially in severe AD. He co-led the landmark Inquire About Tolerance trial and has chief investigator in the Treat of Severe Eczema in Children's trial, founded by the UK Department of Health, which compares cyclosporin with methotrexate in children with recalcitrant AD. And he leads the UK-Irish Atopic Eczema Systemic Therapy Register, you may know it as A-STAR, as well as the European Dream to Treat AD. And he also directs the GADA project. He is the founding director of the International Eczema Council and past president of the British Society of Pediatric Dermatology, as well as an honorary member of the Société Française de Dermatologie. He leads the European Euroguiderm and the management guidelines for atopic dermatitis with colleagues from Germany, and is founding editor of the evidence-based dermatology section of the British Journal of Dermatology and a clinical trial editor.
So sorry, Paula. You're doing so well.
And that's it.
No, thank you for the very kind introduction. Thank you. So very good to be here and to watch Bocas Juniors yesterday with Ellen Irvine rocking in the stands was absolutely amazing. So I'm going to tell you about allergen allies, strategies for preventing and reducing food allergies in babies with atopic dermatitis. Here are my conflicts of interest. Now, some of you may even have children with allergic diseases, and you may have witnessed a severe allergic reaction. I mean, you see respiratory distress in the moment, drooling. You'll see how the skin inflammation is lighting up where this child used to have atopic dermatitis. But in the context of this talk, the question is, how did this child become allergic to cow's milk in the first place? And it's important to bear in mind, based on the study evidence we have and clinical experience, that well over 90% of food allergy is preceded by atopic dermatitis. In other words, children react to the food on first exposure with the symptoms that you've seen in the video. How is that? Well, we think the main route to food allergy is through the gateway of the skin. About 10 years ago, a colleague of mine is a pediatric allergist at my hospital, Guy's and St Thomas's in London. As part of her PhD, hoovered baby cots for house dust and looked at peanut protein content in the house dust and found a clear correlation between how much peanut protein was in the house dust and challenge-proven peanut allergy. Overall, and more so in children with atopic dermatitis, and even stronger as a correlation if they had more severe disease. So back in the day, we thought, well, must be somehow that it's the antigen-presenting cells that are already upregulated in children with atopic dermatitis, that with their dendrites are reaching up to the top of the epidermis, recognizing environmental proteins, in this case, peanut protein, causing the sensitization. And once you're allergic and then exposed orally, you get the allergic reactions. And then we looked at this question in the Inquiring About Tolerance trial, which I co-led with Gideon Lack, which is a birth cohort study to assess whether introducing allergenic foods, 6, cow's milk, eggs, sesame, wheat, codfish, and peanut, from 3 months of age alongside breastfeeding was able to induce tolerance to these foods compared to exclusive breastfeeding for 6 months. And we showed that and published that in the New England Journal in 2016. But in the EAT study, we also have very detailed phenotypical information on atopic dermatitis during the first 3 years of life. And we have information on moisturization frequency in these children. Over 1,300 babies recruited from England and Wales into the study. And you can see on the graph on the right-hand side that the more frequently you moisturize the baby, the more likely that this baby will develop challenge-proven food allergy by 3 years of age. In particular, if the baby was moisturized more than daily, on the very right-hand side here. That's quite a dramatic effect. And we wondered at the time, because we never gave detailed hand hygiene advice in the EAT study, that was because of cross-contamination. You can imagine parents eating a peanut sandwich and then without washing their hands, moisturizing their baby. In other words, massaging small amounts, not visible to the naked eye, of peanut protein into their child's skin. And as they're massaging, they're opening up the skin appendages, in particular the hair follicles. Well, this study, published in JACI in 2021, was one of the main pieces of evidence that was enough for the European Union Horizon 2020 joint program initiative to fund our trans foods project. I put together a consortium of people, not just from King's College London, but also Germany, Bonn, and Berlin, and a colleague from France is taking part in this as well. And what we've shown, this is currently unpublished, is that if you massage the skin with a peanut protein-containing solution, that the peanut protein gets trapped in the hair follicles. So it seems to be true, as you're moisturizing, you're opening up the hair follicles, the peanut protein goes into the hair follicle. And we've also shown experimentally that the protein can stay in the hair follicles for up to 4 days. So there's quite a bit of time for dendritic cells, for instance, that hug the tree of the hair follicle coming into the skin to make contact and recognize the peanut protein as a danger signal. We've also shown, and this is in mice, currently under review, that stretching the skin of mice that have completely normal skin just 3 times, 20 minutes each, about a week apart, by itself, triggers an immune response, including an influx of monocytes, neutrophils, and dendritic cells, plus inflammatory cytokine release. And that repeated stretching over peanut protein-containing solution application leads to peanut sensitization and an increase in total IgE, somehow closing the loop, and you don't have to disrupt the barrier of these mice. We want to make a difference to prevention as well, and one of the obvious things is hand hygiene. So what we've done is contamination experiments, whether we can, for instance, transmit peanut protein from the hand to an arm or a leg, and we've done washing experiments, both with harsh soaps, the type of hand gels and soaps you would use in the hospital setting, but also with soap substitutes, which parents who have sensitive skin and eczema would probably use as part of their routine, rather than wanting to frequently wash with harsh products that would make them more likely to have eczema flares. And interestingly, even the soap substitutes remove the peanut protein adequately, it seems, which is really good news. Now, it's important to remember in this context that not all studies have shown an increase in food allergy in relation to moisturization frequency. And I think Alan Irvine, for instance, has looked at his own data set of his intervention study to see whether he was seeing signals, and he didn't. I think that's because it's not just about the skin, but it's also about the gut exposure. You know, two sides to the coin. And if you are in a setting where people are regularly introducing allergenic foods and weaning their babies early, let's say from 3 months, and the baby's seeing the protein by mouth early, then that will induce tolerance. Babies who are exclusively breastfed for longer periods of time, following the UK guidance for infant feeding of exclusively breastfeeding for 6 months, and if they then also have skin inflammation, are at the highest risk of developing food allergy through the skin. But if you're tolerant already, and then you see the signal through the skin, it's very unlikely to become allergic. This has been conclusively shown in mouse experiments too. So just to wrap up with some take-home messages, food allergy seems to be developed primarily through the transcutaneous route. Early introduction of foods is the best way to achieve tolerance from about 3 months, and this is how our ancestors would have done it in the past, or how the Amazon Indians, for instance, still do it. It's important to understand the role of skin care and skin massage for prevention, of course, and meticulous hand hygiene before baby massage or moisturization use is something we can, as dermatologists, allergists, pediatricians, primary care physicians, easily advise our parents, our patients, may be sufficient to remove food protein. Thank you very much.
We'll take questions at the end. All right, it's my pleasure next to introduce another early member of the International Eczema Council, and that's Dr. Sandipan Dar. Dr. Dar is professor and head of the Department of Pediatric Dermatology at the Institute of Child Health in Kolkata, India. He's been key in establishing pediatric dermatology as a subspecialty in India. In 2003, he authored the first book on pediatric dermatology in Skin of Color, now in its 5th edition. And he has authored more than 300 scientific papers and has delivered so many international and national lectures. He's been the president of the Indian Society of Pediatric Dermatology, editor-in-chief of the Indian Journal of Pediatric Dermatology, and, as mentioned, a long-term counselor of the IEC. I'm also delighted to serve with him on the board of directors of the International Society for Pediatric Dermatology. So he'll present Beyond the Surface, examining the diversity of atopic dermatitis in pediatric patients with skin of color. Welcome.
Thank you, Amy, for the very kind introduction, taking out a lot of time to introduce me. Thanks a lot. Good evening, buenas noches. Well, I'm going to speak about the presentations of atopic dermatitis in skin of color, particularly in reference to my own country, India, and entire Southeast Asia. Before the slides are actually ready, let me share with you certain important things. India is considered as the mini world in the sense that There are 28 states in India, more than 1,500 languages, more than 3,000 dialects, and wide variation in environmental, food habits, wearing apparels and practices, cultural practices, and so many other things. So we get to see different variants of atopic dermatitis in different parts of India. So this is my institute, Institute of Child Health, where I established the Department of Pediatric Dermatology nearly 30 years ago. And many works on atopic dermatitis have been carried out, are being carried out from here. I don't have any conflict of interest. And at the same time also I give a disclaimer that many of the photographs being shown here, we have taken appropriate consent from the parents as well as assents as and when it is, applicable. Now, if we come to the clinical presentations of atopic dermatitis as we see in the Western textbooks, that type of classical presentations of infantile atopic dermatitis occurring over the face and extensors, then from infantile to childhood phase, gradual encroachment of the flexors, then in adolescent and adult, lichenifications is seen only in approximately 40% of the cases. Rest 60% we see different phenotypic variants of atopic dermatitis. These are the classical presentations of atopic dermatitis. However, what we see in our practice is a child is being brought with just, 4-foot dermatitis like this. And when you have got a high degree of suspicion, you take a history, you will find that there are many associated atopic diathesis in the child, like allergic rhinitis or bronchial asthma, or in the other family members, siblings, parents, or in the last 3 generations. This is very important, and you have to label it as a 4-foot eczema. In bracket, I always write atopic dermatitis variant, because the moment you utter these words, atopic dermatitis variants, there is a world of difference in your approach to the patient in terms of management, in terms of counseling, in terms of prognostication, and all these things. This is follicular eczema. I'm going to share with you what types of eczema we see in our situation. Nummular eczema, multiple nummular eczema in a child is nothing but atopic dermatitis. Bilateral eyelid dermatitis is same as atopic dermatitis in pediatric age group. Some of the beautiful places in India, as you can see, Taj Mahal, I'm sure many of you must have seen. Then infra and retroauricular dermatitis. Many a times, I work in a child hospital, many a times, and we closely interact with pediatricians. We have got pediatric super specialties. And many a times, our pediatrician colleagues, they treat them with antifungals, antibiotics, and we often tell them that, look, this is nothing like a fungal infections or intertrigo or a bacterial infections. You need to treat it as an atopic dermatitis. On the very first day, you have to tell the parents that, look, this is something which is very chronic and chronically relapsing disease, and be ready for a long-term, long-drawn battle. It is not going to disappear in terms of in few weeks or few months. And the moment you say that, that gives a rough idea in the minds of the parents, and they adhere to the treatment. The compliance increases. That is the most important, aspect of it. Many children are brought to me that, doctor, my child's, lips are burning whenever he is taking some, hot food or food containing chilies or otherwise also. So this type of burning and erythema over the lips is nothing but atopic cheilitis, and you have to treat it on a long-term basis. As a compensatory phenomena to take care of their burning, many children, they just lick the lips. As a result, you can see lip lickers dermatitis. Posterior thigh dermatitis, as it is seen in the West, is more or less same. In our situation, only thing is that post-inflammatory hyperpigmentation is very difficult to treat. I shall show it in a short while from now. Now come to something very interesting. This is what we have known over the last few decades, that for lichenification to set in, the dermatitis should remain for at least 5, 6, 7, 8 years. That is what our conventional concept is. However, this is just a 3-month-old baby, which was brought to me, the baby was brought to me with excruciating pruritus. Then parents, they were absolutely, mad, gone crazy. The child is continuously scratching, and as in our part of the world, pinworm infestation is a very common cause of vulvovaginal pruritus in, very small kids. Lot of anthelmintics have already been pumped in. There is no response. And look at the, 3-month-old baby's, vulvovaginal skin. Do you think it is normal? It is lichenified. It was nothing but an atopic vulvovaginitis, and baby was treated with long-term antihistaminics, cetirizine, and topical application of, very mildly potent steroid, and subsequently primacrolimus, and a lot of moisturization. And the baby got completely cured of it. The counterpart is atopic penoscrotal dermatitis. I love to answer some of the questions. I have to run a bit first so that I can finish on time. Now, the two most challenging aspects of treating atopic dermatitis in skin of color is, one is treating lichenification. There is not a single drug till on the earth, even MABs and NIBs being present currently, which can treat successfully lichenification, because you treat a child with atopic dermatitis, you are happy, parents are not happy, because the lichenification are not going. So that is very important. See, there is not a single drug which can control this lichenification, which can completely make the skin normal, which is the expectation of the parents and the child. Another is very disfiguring hyperpigmentation. This, child was actually not accepted in the school for 2 years, the photographs which I showed to you, because of hyperpigmentation. Then with dupilumab, we found excellent result with the resolution of hyperpigmentation. I have another presentation. Day after tomorrow, I shall be sharing detail about it in that. Some of the places in India, I shall be finishing my presentation in another half a minute with this interesting case. Look at the face of this 1-year-old boy. What do you feel? This is telltale evidence of atopic dermatitis, isn't it? Obviously, in any other part of the world, it will be diagnosed as atopic dermatitis if it is shown from the color atlas of Pediatric Dermatology book, like my own color atlas book. But I'll show you the next picture. Look at the trunk. What do you see? There are multiple miliaria, which is very common in the tropical climate of India and subcontinent. This is miliaria which develops in a place where the temperature soars up to 30 to 45 degrees during summer, and the relative humidity is 80 to 95%. As a result, multiple miliaria, the child starts scratching vigorously, there is eczematization, and which looks exactly like atopic dermatitis. Something more interesting than that. Now we are having a study in our institute. There are 2 studies. The scabies, you all know that scabies produces an eczema over the face in small babies, which look like atopic dermatitis. But what happens afterwards? We are following up those children, and we see many of these children develop full-fledged atopic dermatitis after 2 to 3 years of the scabies incidence. Same thing has been happening with miliaria. That means these children had atopic diathesis, which actually unraveled their status and brought them to full-fledged atopic dermatitis. And this is India's geographic variation of temperature. If I can show you with this pointer, the red areas are basically very hot, yellow areas are relatively hot, and the green areas are relatively cold areas. So majority of India, from March 3rd week till October, more or less 7 months, undergoes the hot and humid climate with miliaria formation. And that the miliaria histologically also, clinically also, that it is a subclinical miliaria, it triggers atopic dermatitis, is well established in literature. Thank you very much for your patient hearing. Yeah, I think now I have a very, important duty. It is my privilege and honor to introduce Dr. Lawrence Eichenfield, popularly known as Larry Eichenfield, who actually does not need any introduction. I think we can save time, but I think there are many of our younger colleagues who would like to know about this, legendary figure in pediatric dermatology. He had been the past, he has got many things, which if I take for next 2 hours, we'll continue. He has been the past editor of Pediatric Dermatology and someone who has contributed hugely to pediatric dermatology and atopic dermatitis. I am sure that all those who have been working, our younger colleagues and residents, they are quite familiar with his name. I think for the time being, that is in very short, I can introduce him so that he can do justice to his talk. Over to you, Larry.
Thank you for that kind introduction. So it really is a pleasure to be here among so many colleagues and friends from all over the world. Paula, congratulations on assembling people from all over. And I am thrilled that we're sort of starting off the World Congress discussing atopic dermatitis from a pediatric perspective, because just think of the changes between the last World Congress and now. We're at this time of incredible change. The topic I was given was tips on topical therapy. So I'm going to sort of do a mixture of some data on some new topical agents, but then also sort of how I process them in clinical practice, being highly aware that there's tremendous variations in terms of where newer topical and non-steroidals are in our armamentarium of therapy because of differences in the regulatory approach to some of the non-steroidals as compared to topical steroid agents. So we've been involved at Rady Children's Hospital in the testing and design of studies for many of the topical agents. And I just want to start off with my takeaway, which is obviously topical care is still much of our atopic dermatitis management, taking nothing away from the incredible systemic agents that we have that Amy will discuss as well. And we still have our general approach of care plans, which include anti-inflammatory agents as well as our moisturizers. And my messaging, regardless of the severity of the patient when I see them, is going to be that we want to establish high effectiveness of our therapy to minimize itch, minimize rash, and minimize sleep disturbance as part of long-term disease control, whether that be with topicals or systemic agents. So say I have a 6-year-old with moderate atopic dermatitis. Family reports she responded well to a medium-strength topical corticosteroid, but the mother's concerned that the eczema recurs within a few days of stopping the medications. So what's our perspective and what are our options? So we many times have a different perspective than the family might. We'll come back to that because increasingly social media is influencing parental perspectives that the eczema is recurring because of the topical corticosteroids potentially, with the concerns about what's called steroid addiction. But we have several options, including using intermittent topical corticosteroids, or topical calcineurin inhibitors. We have now a variety of PDE4 inhibitors and an arrow-hydrocarbon receptor agonist, as well as topical JAK inhibitors that can be used depending upon age. In the US, that's approved 12 plus, not down to age 6. So we have evolutions in terms of topical ruxolitinib as a topical JAK inhibitor approved in the United States ages 12 and older. Clinical studies already been completed down to age 2. Tapinarof, this novel arrow-hydrocarbon receptor agonist, already approved in the United States for atopic dermatitis from age 2 and older. Roflumilast, initially approved ages 6 and older in a 0.15% cream and a different formulation for younger children, not yet approved. And topical crisaborole, our first PDE4 inhibitor that's changed its labeling not just for BID use for 8 weeks and then as needed for a year, but it was used as a once a day, every day for a year in clinical studies showing marked safety. Now, before going into some of the information on the newer nonsteroidals, I want to come back to my standards in practice, which is topical corticosteroids. It's still, I tell my patients, for me, topical corticosteroids are a hammer for eczema. I have mini hammers with my, low strength, low potency topical corticosteroids. I have nice work hammers for medium strength topical corticosteroids, and I have sledgehammers, right? Clobetasol for a 2-year-old is going to bang more than what we want to bang from that. And so I relate to them the sensibility about safe use of topical corticosteroids. This is a 4-month-old child who was admitted to our hospital with failure to thrive, hypoproteinemia, hypoalbuminemia, metabolic abnormalities, elevated LFTs with atopic dermatitis. The mother had severe atopic dermatitis and believed that she had steroid addiction, and to be truthful, she clearly had steroid withdrawal phenomena clinically and would use no medicine on her child because of her fear of topical steroid addiction or withdrawal. Now, Wednesday in the ISPD lecture, I'm going to discuss topical steroid withdrawals, topical steroid addiction, and some of the data on that. But I think we're aware that steroid phobia is different than it has been in the past, with families being quite concerned about long-term problems with what is called steroid addiction in terms of the literature. And we have some papers coming out, some of which are well done, and some of which I'd say are well done but problematic, that we'll be wrestling with over the next few months. There was a good paper surveying patients who reported that they had topical corticosteroid withdrawal from a social media questionnaire that was done, and a recent article from the NIH that talks about topical steroid withdrawal and has a clinical arm on it. And to say we have to wrestle through that because it's pretty problematic, not using any standard outcome measures for atopic dermatitis clinical studies in that particular paper. Now, if you want to be academic, you can say, how can I compare my topical steroids and non-steroids? And you can look for meta-analyses to look at this. But unlike some of our meta-analyses that we have for systemic agents, I think it's very, very difficult to really do meta-analysis. So while, for example, this was a well-done network meta-analysis, the problem with topical agents is that we did not have standard outcome measures for even 25 years ago when we had our topical calcineurin inhibitor study, and certainly with topical corticosteroids. So example, like with this very good study, what they listed as the agents that ranked most successful was superpotent topical corticosteroids and tacrolimus 0.03%. That's what the study showed, but it was that study with the tacrolimus was in a study with 60 patients that was judged to have a high risk of bias. So we're back to clinical practice to do our comparisons of these agents. I don't find that meta-analysis changes my perspective. Now, the next takeaway is that we have this evolving aspect of non-steroids. And the next few slides are just going to show you that there's a lot of literature coming out beyond the TCIs. And so there's just a large list of articles studying either topical ruxolitinib, topical roflumilast, expanded topical crisaborole, or tapinarof, the arohydrocarbon receptor agonist. But before we do that, I want to just talk about sort of what our real outcome measures, our standard outcome measures might be in terms of relationship to clinical practice. So let's say I have a child with moderate atopic dermatitis, okay? And I put them on a standard mid-strength topical corticosteroid. In the US, it could be triamcinolones, our standard, but think what your standard topical corticosteroid is for BID application for 4 weeks, moderate atopic dermatitis, average of around 15% body surface area. Okay, that patient. How clear would they get? Well, so BID application, 4 weeks, you think they do pretty well. So how do you think they do in terms of their clear or almost clear score? 50%, do you think? 75%? How about their EASI 90 score? And how about the 4-point drop in itch? Well, this study was sort of done in an arm of a trial for topical ruxolitinib, where they actually did BID application for 4 weeks for triamcinolone cream. And the outcome was actually pretty miserable. Almost clear was only 25% with the topical corticosteroid, only 15% EZ90, and only about a third of patients who had a 4-point drop in itch. So my takeaway is sometimes we project our results of how well the topical corticosteroids are a little stronger than they might be, at least based on this more rigorous clinical trial. Now, the next set of slides is basically to show you some of the data set, which can be summarized as the newer nonsteroidals can bring a fair amount of efficacy. This happens to be the phase 2 clinical trial of topical ruxolitinib that showed that it outstripped 0.1% triamcinolone. It's the only comparison we have right now of a topical corticosteroid to some of our newer nonsteroidal agents. Their core study was an 8-week BID study in patients with mild to moderate atopic dermatitis. It did quite well with about almost a 55 to 60% clear or almost clear rate in the 8-week BID. Topical tapinarof, this aryl hydrocarbon receptor agonist, very little found in the bloodstream. Initially approved for psoriasis in the United States, but we have our clinical studies completed with approval of the drug down to age 2 in the United States, with about a 46% clear or almost clear with Q-day application over 8 weeks, with the patient-reported outcomes showing very reasonable response rates as well. Safety and tolerability seemed quite good in the 1-year extension study as well. And with all of our newer nonsteroidals for our PDE4 and aryl hydrocarbon receptor agonist, we don't see any longitudinal studies where we have higher risks with the use of those products topically. Topical roflumilast is a PDE4 inhibitor, which in the US was initially approved in a 0.3% concentration for psoriasis, not in children, then for seborrheic dermatitis from ages 9 and older, and it was reformulated at half the strength and tested for atopic dermatitis in patients 6 years of age and older. And then a lower strength cream, 0.05%, was studies on to age 2, and those studies are filed without having clinical approval yet. May not be as robust a clinical response in the outcome measures. You're seeing around 35% of patients make it clear to almost clear, but this is with a 4-week outcome of Q-day application. They have gone on and showed safety in longer-term studies as well, and they've completed the data already published in 2 to 5-year-olds with the lower strengths. Data, but not yet in clinical approval in the US. Very interestingly, in the United States, we do not have a label for maintenance use of any topical agent for atopic dermatitis, unlike the label in certain parts of the world for tacrolimus to be used proactively. With roflumilast, they actually allowed patients who made it to clear to go on a twice-a-week proactive regimen, and patients did quite well with maintenance of clearing for a median of 281 days. So pretty good data set for that. And lastly, just to mention, not yet in children, but in adults, delcasitinib, which is a pan-JAK inhibitor, is being developed for chronic hand eczema with very nice outcomes and the adolescent studies to follow. So now I'm going to move over to some tips, and it's sort of hard to be, this is what I do, do you care? I don't know. But I'll just sort of, that there's a basic approach now as I'm figuring out from a perspective, which of my topical agents am I going to go with? Is it just topical corticosteroids? How will I mix and match? And of course, what I'm assessing the first time is really the background aspect of the disease, assessing the patient age, very much the family experiences with the disease and the therapies, because that does influence their sense of how they may want to assist with treatment. So, and then I sort of bring it through the sorting cap to sort of figure out, which agents which agents from a topical or systemic standpoint. I think one of the problems with atopic dermatitis that makes it so difficult is that the patients want to tell their story, and we need to hear their story. Sometimes I don't want to hear their story. Their story can take a long time, but it's one of the challenges that we face with the disease because it is so complicated, as you heard from the earlier talks, both in terms of pathophysiology, onset, and our inability to predict what the outcomes will be for individual patients when we see them. But when I'm going and listening to the story, I'm trying to assess the onset and the course, the prior therapies, how they were used in their response, how much medicine did they use in the past, any complications, comorbidities, and very much family concerns, because in our new world with families are concerned, the steroid phobia being so heightened, I need to assess that as I figure out my plan and put on our little sorting cap. New challenges in the United States in particular is that, while some families are coming in for my expertise, we increasingly have families who want to figure it out on their own. And it's this challenge between you're the expert, but I'm going to figure out what we think we want to do. And certainly we've always dealt with alternative and complementary medicine. Years is that volumetric prescribing can impact on outcomes. So what do I mean by volumetric prescribing? When we're giving an oral medicine, say I'm treating an ear infection, we don't give the patient some medicine and say, use it for as little as you can for a few days. You document the quantity that you want the patients to use. And we've actually designed, for training pediatricians, a system in our electronic medical record where we estimate the volume of use that we want patients to use based upon their body surface area. And we've been able to train people straightforwardly. If you use the easy score technique of estimating body surface area, which is for small volume, it's hands, and for larger volume, we just do what I call 10, 20, 30, 40. It's the way I train. I just change the order for it. So it's head and neck is 10% of the body, arms are 20% of the body, trunk is 30%, and butt and legs are 40%, unless you're under 8, and then you borrow 10% from your legs and you bring it up to the head. And you do that a few times, it's pretty quick for people to do body surface area assessment, and we've been able to train our specialists as well as our pediatricians to then plug it into the calculator. And this is an example of a 13-year-old, and not including the face, he's got 50% body surface area, 30% body surface area involvement, and it spits out a number that if we were to do BID application of a medicine, it would take 53 grams per week, based upon basically a cubic regression model on body surface area, and that can really help drive us to clinical response. Many times I'm just talking to my patients about we have to decide which bucket of therapy they're in. Are they going to stay in the topical bucket or are they going to leap over to the systemic bucket? And don't underestimate the utility of our topicals. This was a patient who was admitted with really an exacerbation of an ichthyosiform erythema and edema. The child at the time had this for 3 weeks, started with what was thought to be facial eczema, and then the mother noted the patient turned fussy, the child was admitted, had no evidence of any problems with growth, had normal metabolic parameters, no family history of atopy, but mom had seasonal allergies. We did an ichthyosis workup. In the meantime, the child got a little mid-potency topical corticosteroid and mostly cleared. The takeaway, this child ended up just having pretty severe atopic dermatitis with negative ichthyosis panel, had 2 weeks of topical corticosteroid and was maintained on a non-steroid with occasional use of topical corticosteroids, and at 2 years follow-up has an occasional little focal atopic dermatitis. So we have to respect our traditional agents as well. So in summary, where are we? We have new topical tools in addition to our non-steroids and topical TCIs as well. We have limitations of all the clinical studies I showed you quickly because those are all monotherapy as compared to vehicle. And in clinical practice, we have the options of mixing and matching between our newer therapies and older therapies. So our modern topical landscape's now sort of acknowledging that we have broader set of non-steroidals, how they face in relationship to our topical corticosteroids, we'll be figuring out in practice over the next few years. So thank you very much for the opportunity.
So now it's my pleasure to present Dr. Amy Paller. You all know her, of course. She's a Walter Hamlin Professor and a Chair of Dermatology, Professor of Pediatrics, and the Director of the Skin Disease Research Center at the Western University Faber School of Medicine in Chicago, and she is the President of the ISPD and the American Dermatological Association. She has also given the inaugural IEC president, is the co-founder and a co-founder of the IEC. She has been president of many dermatologic associations, and she has published more than 100 peer-reviewed papers. And together with Dr. Eichenfeld, she was the inaugural co-chair of the Pediatric Dermatology of PEDRA, and she is a co-author of Hagrid's Clinical Pediatric Dermatology, and has edited the Journal of Investigative Dermatology, among other journals. Amy?
All right,
My
thank you so
tongue
much.
gets stuck.
Well, it's such a pleasure to be here. We've been very much looking forward to this meeting. I want to thank everybody who's taken the time to come to Buenos Aires for it. I think it's going to be a fabulous meeting. And I'm going to follow that wonderful talk with just talking a little bit about systemics and some of the latest advancements. I put my conflicts up there. Now, the decision to go to systemic therapy is certainly not an easy one for a child and a parent. And I think we all think very carefully about it. There have been many articles written with algorithms that basically say the same thing. And that is that we want to make sure that the child has had optimal topical therapy first. And I really was glad to see some of the pictures that Larry just showed talking about topical therapy, because I think we all see many children who come in with moderate to severe atopic dermatitis. We're often not the first dermatologist, but we know how to treat aggressively early on to get that under control, and that often changes the course of the disease, and these children may need very little after that relative to how they looked when they came in. So not everyone who comes in at any age with moderate to severe disease, and particularly for younger children, needs to go to systemic therapy. But we need to work carefully with the family to do that appropriate topical therapy, to think about other potential reasons, especially in young children. There are many other reasons why someone can come in looking like they have atopic dermatitis and being quite itchy. And then, and only then, do we talk about moving to systemic therapy. Fortunately, we've had many new agents that have become available for us as dermatologists, and the only problem with many of these is, unfortunately, that they're very costly, and that has created an access issue for many of them. And so I do want to take just a minute to appreciate the fact that many who are here at this Congress have patients who largely cannot afford some of the wonderful new biologics and JAK inhibitors that are available. And even in a place like the United States, we sometimes have to go through using some of the other medications, or certainly for anybody under 12 years of age, think about some of the, what I call oldies but goodies of medications that are still available for treating our patients. So we have to remember about phototherapy. We certainly try to avoid systemic steroids, and cyclosporin is a faster agent, but not necessarily a better agent. Methotrexate is one that we probably use more than anything else, and some of the earlier treat data would also suggest cyclosporin and methotrexate being commonly used. Very unusual now to use mycophenolate mofetil or azathioprine, but these are all available, requiring laboratory tests, requiring good therapy, good follow-up for these patients as they move forward. I'm going to focus the rest of the time, though, talking about the new and exciting agents that are available if our patients can get them. They are pathogenesis-based, and that means that what we have learned about what causes atopic dermatitis has now been translating into new therapies that can be safer to use, that can be more effective because they recognize where the problems are and target those. So we have largely those that target the type 2 immune system, and then downstream from that, the JAK system that allows that then to be becoming the inflammation. I'm just going to say a few things. I'm certainly not going to spend a lot of time talking about data we've seen time and again, but rather to update some of the newer data. And first to mention that even for the preschool children, we now have up to 4 years of data with dupilumab targeting the interleukin-4 receptor, and there are no new safety signals. So that's really reassuring. The biggest problem, honestly, is the injection itself and the pain, so I'll talk a little bit about that. We occasionally will see injection site reactions, actually very few in the youngest children in particular, and the ocular surface disease, which is less common in children than what's been described in adults. Overall, 33% achieve what's been called remission after treatment for at least 40 weeks. That is a long period of time without having the disease come back. And for 3 months, we're talking about 54% in one study, and for 6 months, almost 30% that were still doing very well off of drug with a clear or almost clear status. There's a lot of work being done right now to understand the concept of what is remission. Personally, I think remission is off-drug remission and having to be perfectly clear, but definitions will be coming out that will help us all to get on the same page for understanding that. I want to remark that, not surprisingly, there's a marked reduction in the bacterial skin infections in patients who are treated successfully. This is showing the data with the dupilumab, particularly in the youngest age group, but we're certainly seeing this as well with other effective agents. But I think one of the best things about the biologics is the lack of laboratory monitoring being needed. Now, that's great because it means an extra stick that we don't have to do for our patients to get their blood. But it also, to me, more than that, means that it's really, they're so safe that we don't have to worry about looking at laboratory tests. It is important to recognize that the eosinophils can go up, sometimes rather dramatically, and that's really most important because our colleagues, for example, in allergy, who routinely may be looking at blood counts to follow and track the eosinophils, I know in the past have been alarmed by the increases, but they've not been clinically meaningful. The newest area where there's been discussion has been about growth in children with atopic dermatitis and bone health. We have a study going on right now that's a 10-year longitudinal study that really confirmed what has been previously described in the literature, particularly for those children with more severe atopic dermatitis, that there is a decrease in linear growth. Also noted has been the increase in BMI in children. But what was seen in studies with dupilumab, particularly in that 6 to 11-year-old group, where it's most important that pre-adolescent growth spurt getting started, is that there were increases in mean alkaline phosphatase. Now, many of you who are in pediatrics know that we don't really worry when we see increases in alkaline phosphatase coming back as an abnormal laboratory value, because we know that that goes along with growth. But this was noted, and I want to give kudos to Alan Irvine, who was really somebody who just was a proponent of moving forward and keeping a close eye on this. And it turned out that there were other bone biomarkers subsequently run, and they too suggested improved bone health. Now, we know that there are many reasons why there can be decrease in linear growth, the reduction in inflammation, very importantly, the better sleep associated with less itch, and maybe a reduction in the use of topical corticosteroids, but certainly many of these children have been given courses of oral steroids to keep them under control. But early evidence is suggesting as well that if one can reverse the inflammation of the atopic dermatitis, in this case with the dupilumab, that at least in those with less than the 40th percentile of height at the very beginning, those having at least a 5% percentile increase was achieved by 52% on the dupilumab in 51%, and just by 16 weeks in 31% on the dupilumab versus a much lower number on placebo alone. So what am I pondering now as I think about systemic therapies? Well, first, now that a biologic is approved for children as young as 6 months of age, given the strong safety profile, is that going to be lowering the threshold We all know that we hesitated to even bring up the possibility of systemic therapy when we really only had immunosuppressants to use. But now it might change that algorithm a little bit. What is optimal topical management? And to me, it's no longer keeping somebody once or twice a day on a medium or more potent steroid to keep them in reasonable control when we have something that's probably safer than day after day putting on these potent topicals and a large burden for the family as well. So how long, how potent do we need to go to talk about optimal topical corticosteroid therapy? I'm also thinking about the disease course and whether if we start a medication that's highly effective early on, it's going to change the disease course. We can take that a step further and think about, will early aggressive treatment that improves the atopic dermatitis and perhaps decreases the systemic immune activation, since we know that largely comes from the skin, will doing that actually change the risk of developing other atopic disorders, whether that's the early food allergy, whether that's asthma, whether that's allergic rhinitis, and maybe even some of the non-atopic issues. And I'm particularly interested in issues like attention deficit disorder, which is probably set up early in life in these children and maybe relates to the circulating levels of the type 2 immune system, cytokines and chemokines, perhaps also to the early effect on their ability to have neurologic development of just having this chronic itch and the chronic issues with sleep. Now, there is a study that's a real-world study called the BioDay study out of the Netherlands, and even though we will need long-term studies, large numbers of children starting very early to answer these questions, I think it's encouraging that this study of 84 children on dupilumab for 52 weeks, among them many who already have some of these disorders that are associated with atopic dermatitis, have shown improvement in these other parameters, looking at improvement in asthma scores, looking at reduction in aeroallergen-specific IgE levels, and looking at reduction in the specific IgE levels of the common food allergens markedly being reduced. But the fact remains, we need to see if we can actually prevent these. We need to see if we can change the course of the disease, leading to long remissions in a percentage of children who are treated, and then what are the predictive biomarkers that can help us to understand who will go into that state. And then I'm also wondering about an impact on the developing immune system. So as far as we know, theoretically at least, having targeted therapy will not affect responses to vaccines, for example, will not affect the developing immune system or even safe in patients with immunodeficiencies. But we know that the online information about these drugs and their use tells us that we should be waiting to start the drug or taking them off for at least four weeks with dupilumab before a live vaccine is administered, and then waiting another 4 weeks or so. Is that really necessary? And we're getting increasing anecdotal information that at least children seem to be doing well in terms of their tolerance, but we need long-term data. I want to just very quickly talk about some of the other agents. IL-13 inhibitors, tralokinumab and lebrikizumab, in many places of the world are now available for adolescents. I will remind you that even though they both target interleukin-13, they have different mechanisms for doing that, so they are not identical. Lebrikizumab targeting interleukin-13 in such a way that affects its binding to the heterodimer of the interleukin-13 receptor and the interleukin-4 receptor, whereas tralokinumab binds to the cytokine in such a way that it affects its ability to bind to not only the type 1 receptor, but also the decoy type 2 receptor, and that may affect recycling of the interleukin-13. We also know that you can go from dupilumab and not having a response to actually responding to one or the other of these two, and all across. So they're quite different agents. Quickly, tralokinumab data looked good in the 16-week trial. These patients got a single loading dose. And as you can see, we have numbers that, even though not head-to-head with the other ones, suggest a little bit lower impact on IGA, clear, almost clear, or EASI 75. I think it's interesting in these studies that those who achieved those levels were re-randomized, including going to an every 4-week dosing of the tralokinumab. And many of them did very well, as you can see, with about half of them maintaining that good control over a prolonged period of time without rescue. The lebrikizumab was a little different in its design. As you know, one gets a double loading dose at the beginning and then 2 weeks later, which probably give early higher levels. But it does have a better effect than what we just saw, and something a little bit more equivalent to the dupilumab, with about 46% at that 16 weeks out, achieving that clear or almost clear, and the EASI 75 being in the range of 73%. And that's continuing to go up and sustaining that over the long term. And there have been many studies now that have taken them to long term, just comparing all of these various results of the different trials with lebrikizumab, in which the 12 to 17-year-olds were apart but showed the same kind of data seen in adults. Nemolizumab is the newest one coming out. As you know, this targets the interleukin-31 receptor, available for, again, adolescents and above. And of course, the interleukin-31 pathway is thought to be somewhat specific for itch, and that's what this drug does. It's really profoundly effective for itch. And so what you can see is the adolescent subset, when looking at the itch reduction in patients, shows very good results with the nemolizumab versus the placebo, taken out to 16 weeks. And I think the important point is that separation is seen as early as 1 week out, so highly effective for the itch. But these trials were largely done only in children who were also, other than the early monotherapy studies, on topical corticosteroids, which of course is what we do with the other ones as well. But the early studies did show that it didn't have the same kind of anti-inflammatory effect that the other biologics we just talked about had. However, you can see that with the topical corticosteroid, that there were differences in the itch, of course, as just shown, but even in the clear, almost clear, that was barely, but statistically significant. And then as you follow these patients out, though, with the topical corticosteroid, they do very well. So I think this is best for those who have more severe itch. Takes a little bit longer to reduce the inflammation. One thing I will mention, though, that's not commonly talked about is that one of the issues with giving these shots to children is the large volume. And all of the ones that I mentioned previously, we're talking about 1.14 milliliters or 2 millimeters of volume that go into these young children, some of whom don't have a lot of subcutaneous tissue. This one has a volume of less than a half of a cc, so that may be easier for some patients to tolerate. Again, no increase in infections, lab abnormalities, no labs required. The only side effects we're seeing are maybe a risk of new or worsening asthma. There was a lookout for edema as a potential risk not really seen in these trials. I want to now step back and be a little bit practical on tips for our patients who are given biologics. Of course, we talk about safety up front, but the fact that we can talk about something like dupilumab being available as young as 6 months of age, the fact that there are no laboratory tests required, has been very reassuring for parents. We need to warn about the possible risks and how to handle them, including the fact that the conjunctivitis is something that we see across the board with these biologics, and is something that even if somebody has a past history of conjunctivitis, doesn't have to prevent one from taking the biologic, but I'd still get people started early on good lubricants. I would consider having some topical tacrolimus ointment, because what we've done is we've put those on the eyelids. We see this more in patients who have eyelid dermatitis, and by putting it on the eyelids, not directly into the eye, remember the eyelid's very thin skin, it can get through to the eye, and may be something that's fairly easy to use to help to reduce milder disease, or even prophylactically, certainly if there's eyelid dermatitis, and have an ophthalmologist lined up. I think we always want to transition if we're transitioning over a period of a few months. It takes a while for these biologics to kick in and continue the topical medications. A question that comes up often early on from the parent is, how long does my child have to be on this? And the answer is, we don't have clear data that is evidence-based on that, but many children, after being on for a while, and particularly the younger they get, are able to come off. So I think most of us would say, get things under control, stay on for a good year, give yourself a break, and then maybe consider in those who are clear or almost clear, spacing out 2 to 3 weeks or 4 to 5 weeks, et cetera. Probably not worth going much more than every 6 to 8 weeks before you might stop the drug and see how the patient does. And then we do consider another biologic or JAK inhibitor if the patients are 12 years of age and older and have a poor response. But for the younger, methotrexate has been my first-line systemic, unless they're in terrible shape and need something else to bridge. I want to also talk about reducing the pain of giving a biologic, because that is probably, in my practice, the primary reason why it is stopped when parents just give up trying to give something at home because it's been too difficult for them, too stressful, and a struggle for the child. One is when parents bring the child in, and we'll often start in the office with the first injection and teach. Please, please tell parents, don't tell their child that it won't hurt if the doctor does it. This is the worst. It hurts no less when I do it than anyone else, and all it does is erode the trust of that child in me as their doctor. There's also not been any evidence that giving something like acetaminophen or ibuprofen helps, but cuddling the child on the lap in a bear hug is probably the most effective way to calm the child who is getting an injection. What you absolutely never want to do in your office is to get the child on the examination table, and even worse, tell them to lie down. There's a fear response that kicks in the minute that they lie down. So none of that. We want to obviously try to get these to room temperature. That decreases the sting. Sometimes pre-treating with topical anesthetic can be helpful. I'm not sure how helpful because, again, I think that big volume of many of these is a problem. And then we always teach how to give the injections, including how to distract. And there are many ways to do this: audio, visual, playing games, tactile stimulation, particularly like putting on a little ice, but you can rub the skin, vibrate, apply pressure near the site, and these can all be helpful. Just going to say a little bit about the JAK inhibitors downstream. Pediatric, as you know, looks fantastic in the phase 3 trials that include the adolescents. We don't have data yet on younger children with an early and marked and sustained reduction in the itch. The adverse events, I really haven't seen too many, largely the acne, which is of a big problem to many of our adolescents. But again, atopic dermatitis, they're not used to having much acne. It can be difficult to treat when they don't tolerate the topical therapies for acne as well. Haven't seen much of the others, but of course, as shown here, there are other issues. We have to do the laboratory testing every 3 months to make sure, particularly, that we're not seeing neutropenia. Same thing with abrocitinib. It's quite effective in all of the studies that we're seeing. There were specific studies done for teens with this drug, and I would say the same safety profile as upadacitinib, but for some reason a higher risk of nausea, so there are some differences. Now, we don't have baricitinib in the United States, but certainly in Europe it's approved down to 2 years of age, so it is a go-to drug in addition to dupilumab for those younger children, not for me, but for others. And here we can see that particularly at the highest dose, it can be effective for atopic dermatitis with no new safety signals, no serious issues here. And then a few other comments to make before I end. Nice things about the JAK inhibitors is their rapid and strong effect on itch because they are also downstream of interleukin-31. There is an advantage for some of an oral agent. Of course, it eliminates the injection once daily, rapidly cleared, easy to stop or start if we're thinking about seasonal or intermittently for flares. We know there can be advantages for our patients with concomitant autoimmune diseases like alopecia areata and vitiligo, although I will say that we're now doing an NIH-sponsored trial looking at dupilumab for alopecia areata with some quite good results. The big concern, obviously, with JAK inhibitors is all about safety. And typically that is a deciding factor for parents. I mentioned too the acne. That's a deciding factor for some teenagers as well. We don't know if there are differences among these different JAK inhibitors in terms of side effects, but we do know that there's heavy baggage with boxed warnings, and larger numbers and longer term will be needed before we can fully reassure our families that just because we're talking about younger patients who are healthy, that there is not an increased risk even with these more selective agents. And finally, I just want to mention the only network meta-analysis that I could find in the pediatric group, which just came out based on 8 randomized controlled trials, and only the dupilumab data having data less than 12 years of age. But as you can see, we have a similar type of profile to what's been shown in the adult literature, with the JAK inhibitor, and particularly upadacitinib, a little bit more effective, and then some of the other agents towards the bottom in the efficacy profile here. So with that, I thank you for your attention.
So now we call
That's for me? Sorry. Okay. And next, let's call up to the podium Dr. Mark Coe. Dr. Coe is a dermatologist, pediatric dermatologist, and dermatopathologist. He is head and senior consultant at the Department of Dermatology at KK Women's and Children's Hospital in Singapore. He has been an IEC counselor for many years, but he also serves in many, many leadership roles in the Asian countries. He's Secretary General of the Asian Society of Pediatric Dermatology, and he's also on the board of directors and treasurer of the International Society of Pediatric Dermatology. He's been a prolific author on pediatric dermatology, including atopic dermatitis, and I've known him for a very long time because it was a pleasure to have him as a fellow with us in Chicago way back when.
way back then. Thank you, Amy. Thank you, everybody, and thanks to the IEC for inviting me to this session. And it's our first time here in South America, in Argentina. It's beautiful, and I'll come back again, anytime. So moving away from treatment, moving away from pathogenesis, I'm going to talk about multidisciplinary management of psychosocial comorbidities, because I think that's a very, very important topic that sometimes, we do not think about in some of our patients. So moving on. These are my disclosures, and I think all of us know that AD really creates a huge psychosocial impact. In many studies that we've done, not only does it affect the patients, but it also affects the family members as well. And the worse the eczema is, definitely the more the impact on our patients. And we've already known about some of the psychiatric associations with atopic dermatitis, including attention deficit hyperactivity disorder, anxiety, depression, as well as suicidal ideation. And in this meta-analysis, they found that there's a higher risk of mental disorders such as ADHD, sleep disorders, anxiety, depression, conduct disorder, and even autism spectrum disorder, and really emphasizes the need for an integrated, holistic, multidisciplinary management of pediatric atopic dermatitis. In the study by Jonathan Silverberg, looking at the Fragile Families and Child Wellbeing Study, which looked at more than almost 5,000 urban children, they found that a 1-year history of having childhood AD was associated with more than a 75th percentile of mean behavioral scores. That means they had more behavioral problems. And even at 5 years, 9 years, and 15 years, all through childhood and adolescence, you really do see that behavioral problems in these patients. And the most affected domains include anxious or depressed behavior, social problems, withdrawn behavior, attention problems, as well as aggressiveness. A newer study in 2024 looked at the study of early childcare and youth development cohort using the CBCL at 10 time points, and they've looked at both internalizing problems such as anxiety, depression, social withdrawal, and somatic complaints, as well as externalizing problems like interpersonal conflict, aggression, violation of social norms. And they found that atopic dermatitis is significantly associated with being at risk of these emotional and behavioral problems, both internalizing as well as externalizing problems. In our own study, we've looked at behavioral problems. This was our own study looking at behavioral problems in children with atopic dermatitis. We looked we evaluated ADHD as well as other behavioral and emotional problems in children between 4 to 6 years with atopic dermatitis. We used the CBCL for these children, and we found that 10% of them had a borderline or clinical concern with ADHD, as well as 25% with borderline or clinical behavioral or emotional problems. So we really have to look out for these problems in our patients, but not only in our patients, but even in caretakers of children with atopic dermatitis. So this study done in China looked at almost 901 patients, and they found that almost half of the parents have anxiety symptoms or depression symptoms, or even both. And factors that are associated with society were longer duration or more severe AD in the child, and factors associated with depression were higher educational level, moderately severe atopic dermatitis, as well as poor medication compliance. In this newer study, looking at the US National Health Interview Survey, they found that AD was more experienced with difficulties with learning, as well as difficulties with memory. And however, when stratified by neurodevelopmental comorbidities, AD has been found to be associated with 2 to 3-fold greater odds of memory difficulties. However, those without neurodevelopmental concerns is still not associated with learning or memory difficulties. So the effect of AD on cognition, which now we're quite interested in, there's still quite a bit of controversy whether it affects development, whether it affects neurodevelopment. So this study by Vitrup et al. Looked at the Danish National Registers, and they found that in the lower secondary school, children with AD had overall lower written as well as oral graduation grades, but in upper secondary school, they performed similarly to those peers without AD. However, in young men with AD, they found that they scored significantly lower IQ tests compared to those patients without AD. In another study by Sockler, looking at the NIH's study of early childcare and youth development, they found that there was no association between early childhood AD and general cognitive abilities or academic achievement in mid-childhood. So it's really, we're not really very sure if there is an influence of AD on development. Very importantly, it's we have to pick up these patients and we have to try and manage them in a multidisciplinary setting. And if you look at a lot of guidelines, AD guidelines, you see that psychosomatic counseling, this is the European guidelines, you see that psychosomatic counseling is advised for patients, especially those with moderate or severe atopic dermatitis. So at our hospital in Singapore, we have been running a multidisciplinary eczema psychology clinic for the last almost a decade now. And those who are involved include myself, the pediatric dermatologist. I have a few other pediatric dermatologists that also helps out, but we also have a dermatology nurse, a psychologist, as well as a medical social worker, who play a very, very big role in the diagnosis as well as the management of these patients. We also have more recently started running a multidisciplinary clinic with our child development unit, and in this clinic we involve the developmental pediatricians to pick up concerns such as ADHD as well as autism spectrum disorder. So who are the ones that we send to this clinic? Children as well as adolescents with moderate to severe atopic dermatitis, those that we suspect may have psychosocial issues such as low self-esteem, school bullying, anxiety as well as depression, and also those that have family issues. So a lot of them may come from broken families or families that are experiencing a lot of conflict, so we do put them into this clinic as well. And of course, those that we suspect with ADHD or learning difficulties, ASD, we do see them together with our pediatric developmental doctors. So what's our role for the pediatric dermatologist? Of course, is to really control the eczema in our patients. That's we really have to try and treat the eczema in addition to the psychosocial management. But I think more importantly is how we can detect these psychosocial, behavioral, and developmental concerns in our patients. I think a lot of times, we really don't have a lot of time in the clinic with these patients. So it's important to know your patients very well, right? And to sense when there is some psychosocial impairment, to pick them up early and really to manage them together with the psychologist and even sometimes the psychiatrist. So it's very important to pick them up, and we are the first line, to our patients. So we really have to spend that time to pick up these problems, and that's really our main role in this clinic. The dermatology nurse helps us to reinforce some of this understanding of disease and, of course, demonstrates and how to treat the disease, how to treat in terms of treatment for our patients. And our psychologist is very, very important, and they do look at the itch scratch triggers as well as strategies to break this itch scratch cycle. They talk a lot about stress management. They assess for sleep routine and sleep problems because a lot of our patients really are not able to sleep at night. They also address and assess for effects on the school, social functioning, self-esteem, bullying, and teasing. They also assess for psychological issues such as depression, anxiety, and suicide. And if needed, they will recommend referral to the psychiatrist if they feel that these patients do need psychiatric medications. For the developmental pediatricians, they help us to assess for developmental issues like ADHD, ASD, GDD, as well as specific learning difficulties, and then plan for them to be referred for therapy, such as to the occupational therapist or physiotherapist, and if needed, medications to treat some of these developmental issues. We also involve our social worker, where they help to explore the impact of atopic dermatitis on families. They look at what the parents' worries are, what the difficulties in the family, sometimes referring them to family therapists to treat, to manage the family as a whole. And sometimes they do also provide psychosocial support by referring to external agencies and collaborating with existing resources. And in Singapore, because a lot of our patients pay out of pocket, so sometimes we need to find financial help for them. And as Amy has talked about, treating these less severe patients, but those with psychosocial issues early, with good treatments like the biologics, sometimes, they do get better and their psychosocial problems improve as well. So looking at a study that we've done, assessing our clinic, we find, that both subjective as well as objective scores of atopic dermatitis have improved with the treatment of these patients in our multidisciplinary clinic. And going forwards, now we are trying to leverage more on innovative digital technologies, to manage our patients with psychosocial issues. This is a study that we're trying to do whereby we can just use an app to scan the face of a patient, and the way that they interact with the app, it can pick up subtle psychosocial issues, and with that, at least you get an idea that maybe this patient, you have to spend more time with this patient, really to assess them for their psychosocial issues. So we hope to get this study out into the results in 2 to 3 years. We are also assessing an app called Mind My Skin, which helps as an adjunct for management of psychosocial impairment in chronic atopic dermatitis. We're trying this out in the adult as well as the adolescent patient, and it helps with educational resources, some guidance on disease management, tools for tracking progress, as well as stories from fellow patients. And finally, we're also starting a study looking at the neurodevelopment of infants and young children with atopic dermatitis. There's really very little data on this, because a lot of our patients, and we showed quite a few photos of very severe patients at 6 months of age, and we find that a lot of our parents do not want to treat their patients at that age because of steroid phobia, because of the fear of steroid withdrawal. So if we can show that there is neurodevelopmental disability because of the severe atopic dermatitis, maybe that will give us more impetus or the parents to treat their kids early for their atopic dermatitis. So in conclusion, I think that psychosocial issues sometimes, are not looked out for, especially in a very busy clinic. So it's important to look out, for these patients with psychosocial impairment and to really try and manage them in a multidisciplinary setting. And going forwards, I think we can leverage on digital technologies as well as innovation for detection and management of these psychosocial impairments. So I'd like to just end by saying thank you for inviting us here, and we will be putting in a bid for Singapore, and we hope, like how you have invited us here, we will invite you to Singapore in 2029, so we hope for everybody's support. And with that, I'd like to thank you for your kind attention.
So now we're calling Valeria. Valeria is an associate professor and Valeria Oki. She's an associate professor and director of cutaneous immunopathology laboratory and member of the scientific committee of the dermatology graduate program in the Department of Dermatology of the University of São Paulo. She also is the president of the School of International Relations Office. She has had a long career with interest in understanding autoimmune, infectious, and inflammatory skin diseases in tropical countries. Her clinical interest includes blistering diseases, where she's very famous, inflammatory dermatosis as atopic dermatitis, and mentoring PhD students and postdoctoral fellows in the University of São Paulo. She's a counselor of the IEC and a member of the board of directors and a co-chair of the educational committee. Vale,
thank you, Paula. Thank you very much for the IEC invitation. And So the theme that is we're discussing now is about empowering adherence and education. So I think it's there are two themes that integrate and they're not independent. I think we, as physicians, we have a very, very relevant role in developing those aspects. So we're going to see here, first of all, what about adherence and patient education? So there's a very good publication regarding this theme. Dr. Cole preceded me and he was discussing the relevance of our role of integrating education, the scientific knowledge, the therapies. And I think that this paper really points out that education is fundamental, lifestyle affecting the disease, and the patient-reported outcomes. We are dealing with patients, and it's interesting. I'm going to show to you later how different perspectives from physicians and patients we may get. And also, medication reminders are very important to keep adherence. In terms of adherence, unfortunately, atopic dermatitis is a chronic disease. And chronicity really leads to a big challenge because the longer the disease lasts, less options and less adherence we may get. This is an interesting study published in the Pediatric Dermatology last year where they analyzed 36 studies with patients and caregivers, about 10,000 in numbers, to identify the barriers to treat problems with adherence. So what are the barriers? First, we have a poor caregiver quality of life, inadequate atopic dermatitis-related education, topical corticophobia, unclear therapy-related instructions, and dissatisfaction with physician interaction. So those barriers are present, and what can we do for improvement of this adherence? We can work on caregivers' education programs. We may organize daily text messages reminders, eczema action plans, and also to maybe help the patients, caregivers, and also some physicians about the different topical corticosteroids potencies. It's very important. Here, like in Brazil, I don't know here in Argentina, Paula, but in Brazil, for instance, patients do not need a prescription to get either topical or systemic steroids. Can you imagine that? It's very, very, we don't have control over that. So this is a very important point. And also to enhance frequent follow-ups. This is very important. So for corticophobia, about 7 years ago, there was a multi-centric study involving American, European, South American colleagues with a TOPICOP score. And I think this score is important. I've seen after this evaluation and also consolidation of this TOPICOP score, some studies that utilize this tool. So developing new tools to evaluate those problems are very important. And the question that I was talking to you about, what are the different perspectives from a physician or from a patient in terms of the disease? We know that we physicians, we are usually very interested and very keen on the signals, so the clinical presentation. But sometimes for the patient, symptoms are very relevant. So itch relief is really important for them. So there's a difference of perspectives here, and we have to respect that in order to achieve better adherence and also to offer better education. Just to show to you, this is a patient we saw last week. This is a 30-year-old patient that for the last 5 years at our country, he's been receiving every month 1 injection of steroid. So this happens. It's really difficult. And how can we help this patient to keep the adherence and to get educated in terms of avoiding these procedures. He just goes to the drugstore and gets the medication without restriction. So we have to kind of fight the situations. This is a paper that Professor Peller led, and it's the PET stat as well. And it's interesting to notice those targeted therapies are very important. Why? Because they are probably much more effective than the classic ones, or at least they show less side effects. And look, here is the impact of these new medications in terms of adherence. I don't know if you can see here. The bars in blue, it's dupilumab. The orange is methotrexate, and the pink is cyclosporine. So you can see that the POEN, the quality of life, and other parameters, they get better by the end of the treatment when you evaluate patients taking biological therapy versus the classic generalized therapy. They're all very good. However, it's the immunobiologics in this study, they show a better efficacy in terms of keeping the patient adherent to treatment. And the last part here is about education. I think this is one of the best papers I've seen lately. It's from Nottingham, and it's evidence-based systematic review, and it talks about educational and psychological interventions for managing AD. And in this paper, the authors, they focus on two main outcomes: the reduction of disease severity and secondary outcomes. And here, what do they evaluate? So we know that education is important, but is the education measure that you are taking really helping the patient in terms of clinical signs? So this is interesting. We're going to see that. So they analyze 37 trials and about 6,000 patients. Most of them were children, about 50%, and 27% adults, and the other ones were mixed. So they focused on 7 broad categories. So direct person-mediated education, technology education. We are nowadays with many different tools, printed education material, habit reversal treatment, arousal reduction approaches, self-help psychological interventions, and psychological therapies. Those studies were mostly from high-income countries and outpatient settings. So what did the authors find in this collection of reviews? So first, individual educational intervention. Is it efficient? Yes, it may reduce short-term clinical signs. Group education. So I think in all our university hospitals, we try to organize those education therapies, usually group therapies, right? So is this group education intervention really helpful? Usually organized by workshops or lecture-based. Yes, they do have a good outcome in terms of a scored, also quality of life. But no difference to short-term psychological well-being. So we have to improve, and I think as Dr. Cole mentioned, to really integrate a multi-specialty team here. Technology, we're talking about websites, we're talking about text messaging videos. Are they effective for these educational programs? Yes, they could improve, but we still have too little studies. We have to make more. So maybe in 10 years from now, we're going to have a better answer here, right? So we're still beginning this technology evaluation. The other ones, we still use printed material. Is this printed material useful? In this study, they said that handbook really improved adherence. It's interesting. Most of the patients really enjoy the printed material to keep doing their follow-up. The other ones, not really exciting. Psychological therapies. This is the last item that they really reinforce, and this is the one that is really helpful for the patients, especially for long term. And about, they say here, about 35 minutes per treated patients would be the ideal. And lastly, we're talking about modern technologies, right? Professor Cole here mentioned very nice devices. Hopefully we'll be utilizing them in the near future. And here, in this group, they developed a mobile health app so that 58 participants, so it's a pilot study here. However, if you use for only 1 week, it's not as effective as using for a longer time. So still a beginning here. ChatGPT, this is a recent published study that we performed with North American colleagues, South American colleagues, Professor Stalder, Tayeb, Professor Eichenfield, who's here, Professor Vestergaard, Margarita Terziak, Peter Leo, and Andreas Wollenberg. So it's interesting. We are using ChatGPT, even our medical students. So how trustable is ChatGPT for informing or educating our patients? And we did not only in the English language, but we also translated to different languages. And you can see here that Brazilian Portuguese got the worst evaluation because Portuguese is a tricky language, and I think when you read the information in Portuguese, sometimes it doesn't make sense. So it varies according to different cultures. And it's important. People are using ChatGPT, right? And lastly, TikTok. I don't like TikTok, but we must be aware because especially the young patients, they use TikTok, right? Is there any publication regarding TikTok and the impact of informing about atopic dermatitis? Yes, there is this paper that was just released end of last year. It's a paper about topical steroid withdrawal. So in TikTok, in this paper, they found about a lot of videos talking about this topical steroid withdrawal. And what did they find? 10%, only 10 of those videos clearly defined this condition. So the other 90%, we're not even talking about this. So we have to be very careful, and none of them had at least one dermatologist or even a physician responsible for those videos. So this is only for to make us aware of this new technologies that are in medias that surround our patients. Okay, so again, just to reinforce that the patients are the target for our role as a physician and improving their lives. And I think the patient associations are very important. We have established associations all over the world. And I would like to thank the International Eczema Council. This is the current board of directors. And I would like to invite all the Latin American colleagues that are here joining this meeting to have a look at the IEC and the infinite opportunities for academic life, for established academics, and also for the newcomers. Thank you.
Thank you so much. Why don't you stay up here, and I would invite all of the speakers from today to just come on up. We're a little running over schedule here, but we have enough time for questions. So I know we did not take questions after each one because they were short talks, and we wanted to get through many speakers and lots of information. But this is your opportunity to ask any of us any questions that you'd like, and we're going to stand up here as a panel and be happy to answer them. So don't be shy if you have questions. Do we have a mic? Yeah, do we have a second microphone that the person who's answering could?
It's okay. Okay. I have a question to Carsten. So you propose a very interesting point that the moisturizer may not be good for preventing, not good for inducing or food allergy. So, but I'm also concerned that study may be somehow related to, so the daily moisturizer patient may tend to be severe, related to severe AD patients. So I just want to ask you that point, and also how do you explain to patients about moisturizing or skincare?
Okay, Kenji, if you'd like to give the microphone to Dr. Oh.
Yeah, I think that's okay. Thank you, Kenji. So the first thing, so in the EAT trial, observational study, not a randomized control trial, but showing that link between moisturizing frequency, more than daily, and over 30% increase in food allergy, we saw the signal in those with atopic dermatitis and without atopic dermatitis, which was interesting. And so that although other data has suggested, including the house dust, hoovering data, that the more severe the AD is, the higher the risk of food allergy, in that study we didn't really see that relationship. So, and although I appreciate its observational data, all of these studies adjusted for disease severity and, in past history as much as we could. What do I tell the parents? Very simple, just to wash your hands thoroughly before you moisturize your child's skin. And now, based on the data that we've got with the washing experiments, if it's a parent, very often that's the case, of course, because of family history being so important in atopic dermatitis development, the parent will have eczema themselves and would be ideally using a soap substitute rather than a harsh soap or a hand gel. We can say that there is evidence that that will equally remove the food protein from the skin. What we haven't really done is any intervention studies with that advice to show that that is really true. So, I mean, there's loads more that needs to be done in this space.
Thank you very much. All right, other questions? Yes, Elaine.
I'm so heartened that
Can you take the microphone, please?
So heartened that worldwide, even though we're all in our own silos, that we make the same observations. But one observation that I didn't see made in my patient population, where I have good access to patch testing, and even though that's a terrible study, nobody's mentioning patch testing in some medications. So Fatima, for example, has got propylene glycol in the vehicle. So many of these, and propylene glycols are rising allergy. I do my best to keep kids away from all these topical allergens. I wonder if there's a comment on it. And then another comment is about, patient education and poor adherence. I truly think that if we had an easier treatment to use on the topical treatments that we're using, adherence wouldn't be much of an issue.
Okay, thank you. For those speaking about moisturizers or trials where we're putting on topicals, any particular comment about the choice of the topical that might be used and avoidance?
Yeah, thanks, Elaine. I think it's important the topical regimens and how much we demand from our patients and their families. So emollients that have nice skin feel, that are easy to spread, that aren't waxy, that aren't cold, that don't block the hair follicles, that don't cause acne, all of those are nicer. And I think one of the things when we're talking about infants is it's parental choice as well. If it feels nice, if it feels like you're doing something nice for your baby, you're more likely to use it than something that feels heavy and waxy and medicated. So the choices go with that. In our study, we only asked people to use the treatment for 8 weeks, and we had really high adherence to twice daily when we were through the diaries. But because it was such a short trial, some trials run for a year, and adherence inevitably falls off if you want people to do that for a year. And of course, patch testing, that's super important and often missed, and not everybody's able to do them. And kids have tiny backs, and they remove their strips by day 3, and it's not so easy, but we do it. But we try to be selected rather than just do like 67 random allergens for the real estate available for the test, really.
Yeah, I think we can, of course, that's on the list of things that we look for before we go to systemic therapies. I would say, too, some of the things that the parents talk about are the mess of some of the topical that we use. I mean, we've long talked about ointments being a treatment of choice to help to moisturize, but we've got a lot of variety now and other possibilities, and that does make you have to get clothes more frequently in children who are using lots and lots of ointments. It's a mess around the house, lots of laundry, increased burden. So that's also something to think about. And then, of course, we encourage parents, if they have questions, we're happy to be ingredient readers.
Dr. Shatalina Pradhan, yes. Yeah.
One more question.
Dr. Shatalina.
Hi, ma'am. I want to make a comment regarding this moisturizer. My teacher, Dr. Sandipandar, will agree with me. In India, we use coconut oil, and starting from the day one of life and regular massage. And I don't know about the peanut oil, but we have not seen any allergy. Coconut oil is favoring towards AD. And it has been very beneficial because of its high lanolinic acid content, which prevents the trans epidermal water loss.
Yeah,
So,
of course, coconut oil we prefer, and we have been finding very good result, and most importantly, for a huge population, particularly from the rural setup, it comes at a very cheap cost and fairly good amount of coconut oil they can apply. Here I would like to mention one thing, that whenever I speak to my pediatrician colleagues or my juniors or residents, I always say the treatment of atopic dermatitis should start with use of moisturizer and it ends with good counseling. And that is very, very, very relevant even in the days of, MABs and NIPs. So whether you are giving an abrocitinib or a dupilumab, you should not forget about giving a good moisturizer as well as a good counseling to the parents.
thank you.
Thank you.
All right, well, let's take a minute to thank all of today's speakers. I want to thank all of you for attending and wish you a wonderful World Congress of Pediatric Dermatology.
For a picture, no?
Okay, sure. Speakers for a
Custom.
picture.